Good. We got a full. Ooh. I don't have that. I'm not gonna open a new bottle. That's like really mean. I wish I had my bottle, but it's in the other room. Hey y'all, how y'all doing today? Happy Tuesday, and happy part 2 of this NCLEX maternity review. How y'all doing today? All right, so we are picking up where we left off yesterday. Yesterday, first of all, like I said, hello, happy Tuesday. I'm so happy you guys have decided to spend this like hour or so with me instead of doing something like binge watching the Jeffrey Dahmer Netflix special. And I know that is very enticing for some of y'all, but I'm very grateful that y'all have decided to come with me, okay? I have beat Jeffrey Dahmer. Let me stop. How y'all doing today? All right, so like I said, this is part 2 of our NCLEX live review. Jane said, I'm doing good today, feeling sad and defeated, didn't pass my exam today. Oh no. We're paying attention to celebrity drama. Or the nurse TikTok drama. Because that's also entertaining, let me tell you. But yes, we are doing our part 2 of our live maternity review. We stopped yesterday at Nigel's rule. Okay, so today we're going to be going over the 4 stages of labor and pregnancy complications. Okay. Hello, I'm scheduled for my NCLEX at the end of October and I'm stressed. Ooh, Lord. Good luck to you. You're going to be great. Trini, what was your test on? Eyelash, tell me what your test was on. But yes, thank y'all so much for joining me. We're going to go ahead and get right into it. Also, just in case you guys were not aware, I think I just posted too. Yeah, just in case you guys were not aware, you didn't see my post or the announcement from yesterday. Our Steady Gummies are back in stock. Steady Gummies are back in stock. These will sell out like they do all the time. They've been on sale since noon today. Okay, they were available at noon today. People are already buying up 5 at a time. Just so they don't miss out again. Because like I said, this takes a little minute to actually create and curate. So this isn't like a quick restock. So this is usually restocked once a year. I just restocked it. Get y'all bottles. Y'all have harassed me and bullied me into restocking these for like months. So they are finally here. I don't want to hear nothing. Link in bio, or you can get it on the in the app. Okay, just head to the nursesam.com or download the app, and it'll be there for you guys. All right, let's go ahead and get into our review. All right, so like I said, we are going to be covering stages of labor and pregnancy complications. Okay, now if y'all have never been to, I see you, Trini, mental health and med-surg. Which med-surg? Med-surg 1, med-surg 2, and what chapter or chapters, like not numerical, because I don't know what your chapter 14 is, but like what chapters in med-surg, or topic areas in med-surg. Like, did you just do cardio, endocrine, neuro, what? All right, so let's go ahead and start with the 4 stages of labor, okay? And like I was about to say, oh yeah, also we're doing fetal heart monitoring. If you guys have never studied with me, if you are new to my page, if you are new to my reviews, hello, how you doing? I'm Nurse Sam, licensed practical nurse. I've been so since 2014, so I have been a nurse for 8 years. I created this business, the Nurse Sam Global Media. I created this to help students that were just like me, so visual learners, students that have ADHD that just can't really grasp concepts so easily. I created this business because I wish I had it when I was in nursing school. Okay, I needed a fun and entertaining way to digest and learn all that information in order for it to stick. So I started making notes and doing my own type of reviews, making it very fun, very age appropriate, because I don't know about y'all, but back when I was in nursing school in 2013, 14, loved all my professors, loved all my instructors, but they did things very old school and they taught very old school. And I just felt like I was in someone's like Kojic church trying to listen to the preachings of the Lord. And I don't understand what you're saying. No. So I just needed a better way for me to actually learn the material so I can actually recall it and retain it. Like I needed to want to study within nursing school. So I made my own way, literally made my own style of nursing, style of taking notes. And before I knew it, I started this business back in 2019. And 3 years later, I'm not bedside anymore. I'm doing this 100% full time, and I've helped over 25,000 students get into nursing school, get through nursing school, get out of nursing school, take their NCLEX and pass, and become amazing nurses. So if that sounds like you are where you need to be. Okay? So if you do not have either the maternity study kit, the third semester study kit, or the ultimate nursing school study kit, then you need to get it. This will definitely help you, especially, like I said, if you're a visual learner and just need help figuring out what to study, where to start studying, and how to study, okay? Once again, if you're a visual learner, this is perfect for you, all right? If you need colors and images and just really need to be entertained in order to retain anything that you're learning, this is for you. All right. So everything that we're going to be covering throughout this week and throughout this live is going to be in even more detail within those study kits. Okay. So I'm covering all the hot topics, the hot and commonly tested topics within maternity. So that's why we're hitting the things that we're hitting on. Okay. So use this review, use this study kit supplementally to your textbook. But this, like I said, is going to help you eliminate the fluff and just focus on what's important. Okay? All right. So, like I said, we stopped at Nigel's rule in GT PAL. So let's get into a couple things. Get into the 4 stages of labor and breech presentations. All right. So let's start with the 4 types of pelvises, okay? Y'all know there's 4 types of pelvises, right? And this is where this comes in. This is kind of usually touched on within like the beginning as far as like the basic maternity concepts or the intro to maternity concepts. But whenever there is like insert number here, types of anything, know it. Know it, okay? So 4 types of pelvises, and there's one type that is ideal for childbirth, which is usually the question that I see come up when it's on NCLEX or when it's on your like nursing school exams, okay? So when I do see questions about these 4 types of pelvises, what they want you to know is which one is ideal for childbirth, okay? Because depending on the type of pelvis the client has, he or she may or may not be able to push vaginally or deliver vaginally. Based on their type of pelvis, maybe they're going to have a C-section. So whenever a provider is like doing an OB/GYN workup, especially once they confirm that a patient is pregnant, the next thing that they do when they're doing their assessment, like a prenatal assessment or just your prenatal assessment, they figure out the type of pelvis. So then the care can then be kind of revolving around that. So does anybody know a type of pelvis? Does anybody know a type of pelvis? Like just give me a name. Comment down below one type of pelvis. There's 4, but there's one type of, just name one, okay? And Yeah, just name one. Let me see where y'all at with this. Can anybody name one type of pelvis? If you can't, that's fine. That's why we're hitting this review. Can anybody name one type of pelvis? Just one. Yes or no? Yes or no? Yes or no? Anybody? A type of pelvis. Thank you, Whisper. Yes, gynecoid. Gynecoid is one. Remember, I said there are 4 types of pelvises. All right, so one is gynecoid. One is, this girl said my pelvis. Girl! One is gynecoid. 2 is android. 3 is anthropoid. And 4 is platyploid. Okay? When you see gynecoid, all right, that one, the shape, the shape is like a circle. All right? Gynecoid is the shape of an actual circle. All right? Android is in the shape of a heart. Okay? Anthropoid is in the shape of an oval. So that one is more narrow than wide. All right? That's a horrible oval, girl. Let me find y'all an oval. All right, this is an oval. Kind of. All right? So yeah, this is anthropoid, long, narrow, and oval shaped. All right, the fourth type of pelvis is a platyploid. All right, platyploid. Literally, word-wise, it looks like a platypus. Think about platypus, but don't put puss. You have a platypus shaped puss. I'm just kidding. Platyploid. That is a wide pelvis. Okay, that one is. If this is, my bad. If this is anthropoid, long, narrow, and oval, this is platyploid. All right, it's wide, very wide. Okay, now of those 4 types of pelvises that I just named, gynecoid, android, anthropoid, or platypus, which one is the ideal pelvis shape for childbirth? I'm gonna get into that. But which one is the ideal pelvis type or pelvis shape for childbirth, and which one is the most common female pelvis? Miss Enemy, those 2 answers are the same. The most common pelvis type for women is also the most ideal for childbirth. Gynecoid. Right. Great job, Whisper. Gynecoid is the most common female pelvis and also the one that's ideal for childbirth. Okay? That circle inlet shape, that pelvis shape, all right? Gynecoid. The most common and the most ideal for childbirth. With that being said, let's take it a step further. Okay, which shape would not be conducive to childbirth? Which one would not be conducive for childbirth? If somebody had this type of, if somebody had this type of pelvis, childbirth, like a natural childbirth, vaginal delivery, would not be ideal at all. Not android, not anthropoid. Well, I guess there's only one. There's only one. It's the platyploid. Platypus. Miss Tracy. I can't study with Miss Tracy because we would be out here. No, platyploid is the wide pelvis. Okay? Android is the heart. All right? Android is the heart. Long and narrow is anthropoid. Wide is platypus. The wide. I cannot. If y'all was in my study group during nursing school, yo, we would not get anything done. I'm just kidding. Our study group would have been super fun because this is literally all I did throughout my study kids. and my study groups just made jokes, but jokes that would actually like help us study. Like, but yes, please don't forget that platypus is not conducive, like a wipe is not conducive to childbirth at all. At all. Just kind of, however you gonna make that however you're gonna make that stick, have at it, all right? I'm just kidding, y'all. But yes, gynecoid is the most common and the ideal for childbirth, right? That circle. But platypoid, it's not conducive, all right? So just know that. Now I'm gonna come back and I'm gonna ask you, now which one's heart-shaped? So, in addition to knowing those names, of those pelvic, or the shapes of those pelvis types, just know the actual, in addition to the names, know the actual shape, like which one's heart-shaped. Just be able to, when they give you one part of that information, be able to be like, okay, if they're telling me that, it's a pelvis that's not conducive to childbirth, I'll know that that's a platyploid, which is wide pelvis. So kind of be able to kind of stair step it like that. All right. Now let's go ahead and get into the 4 stages of labor. Wait. Hold on. Done lost my page. I think I did this one. Yep, sure did. Okay, great. 4 stages of labor. All right, there's stage 1, stage 2, stage 3, and stage 4. That part is, let me shut up. Let me just keep going. All right, so when you're trying to identify the stages of labor, they're numerical. 1, 2, 3, and 4. Okay. The first stage. All right, y'all taking notes? First stage actually has 3 phases of it. All right. So when you're thinking about the actual stages, how they're going to, like whether it's your nursing school professors or the creators of the NCLEX test, what they're going to be assessing is that not that there are 4 stages, that you're able to identify what's occurring in each stage. Does that make sense? So they're going to give you like a scenario saying, okay, you have a patient that's interaction here. Which stage are they most likely in? Which stage of labor are they most likely in? So you got to know what happens in each stage and what it looks like. If that makes sense. All right, so 4 stages, right? First stage has 3 phases. All right, now what happens during stage 1? Stage 1, a client is in stage 1 anywhere from them starting to, or her starting to dilate, or dilation to the delivery of the baby. All right. Well, no, stage 2. I lied. Stage 1, I'm so sorry. I was reading the wrong thing. Stage 1 actually is the dilation phase. All right. Stage 1 is before they are 10 centimeters dilated and they start pushing. All right. So that's like, it's like the prep stage. All right. Now remember I said there's 3 phases within stage 1. This is what I'm talking about, the dilation. All right. So from 0 to 10 centimeters of dilation, that's stage 1. Okay. Now phase 1 is the latent phase. Okay. Phase 2 is the active phase, and phase 3 is the transition phase. All right. Now this is how you know which phase of stage 1 it is. All right. It all depends on how dilated they are. Okay. So you have to know these measurements. So make sure, in addition to taking notes about the 4 stages of labor, you know what phases each, like the range of dilation belongs to. So in phase 1, which is latent, all right, that's latent phase, the patient or the client is dilated from 0 to 3 centimeters. Okay. Phase 2, which is the active phase, they're dilated from 4 centimeters to 7 centimeters. Okay, and then phase 3, which is the transition phase, they're dilated from 8 centimeters to 10. Okay, so 0 to 3 is latent, 4 to 7 active, 8 to 10 transition. You got it? Make sense? Okay. For those that are just joining in, welcome to our part 2 of our live maternity NCLEX review. We are going over stages of labor, fetal heart monitoring, and pregnancy complications. All right. Right now we're in the stages of labor. Thank you, Whisper. Ooh. Can I like that? Ooh. Y'all better screenshot that. All right. So yes, those are the stages of labor. And with that being said, y'all lucky she posted that right here, because it's okay. I'm gonna wait for that to pass just a little bit, and then I'm gonna ask y'all a question about it. Okay. All right. So that's stage 1. And the phases of stage 1. Stage 2 is from being 10 centimeters dilated to the delivery of the baby. All right. So think of stage 2 as the pushing phase, because you can't push until you get to 10 centimeters. So once you're there, you're in stage 2. Okay. Stage 2 is from that complete dilation to baby delivery. All right. Now, stage 3 is from the baby delivery to the placenta delivery. Okay, because remember, after the baby comes out, the placenta is that temporary organ between the fetus and the mother that allows the nutrients to be delivered to the fetus. So, what's the name of the I won't say what it is, but what's the name of the thing that's attached to the baby and the placenta? Okay, what's the name of the thing that's attaching the placenta to the fetus? If you were here yesterday for part 1, you know what I'm talking about. But yes, what attaches the fetus to the placenta? Thank you, NC Pink Rose, the umbilical cord. Right. Okay, and if you were here yesterday, let's see if you're paying attention. With that being said, the umbilical cord, how many arteries and how many veins does the umbilical cord have? Just making sure that we all comprehend. Okay? How many arteries, how many veins does the umbilical cord have? All right, AVA, baby Ava. That's how I remember it. Someone else also told me that's how you remember it too. AVA, 2 A's and 1 V, 2 arteries, 1 vein. All right, I definitely know that because that was on like every maternity test that I've at least ever proctored. So yes, stage 3 is from the delivery of the baby to the delivery of the placenta. Okay, when the placenta comes out, remember there's 2 different sides, and so as the nurse, the labor and delivery nurse, you're gonna have to note which side the placenta, which side the placenta was on when it was delivered, if that makes sense. Like which side was shown, because remember there's 2 sides to the placenta, so you're gonna have to be able to identify what side of the placenta is looks like which side looks like what, and be able to identify what it is, like the actual name for it. Okay, but we'll get back into that. We'll get back into that. So after the placenta has been delivered, now you're in stage 4, and that's the postpartum stage. Okay. For the first 1 to 4 hour, well, it's actually 2 different phases. It's a postpartum stage, which is the first 1 to 4 hours after delivery. And then after that, it goes into the stabilizing phase. Kind of let the words kind of help you. Stabilizing phase is the phase where the mom tries to get stable. Baby too, all right? Stabilizing phase. We're resting at this point, okay? Y'all got that? Stages 1, 2, 3, and 4. All right, so I'm about to ask y'all some questions just to make sure that we're on the same page and that you comprehend as much as possible the stages of labor. All right, so I'm about to ask y'all some questions really quick. Okay. Really quick, when someone says they're in active labor, okay, let me just say this. Remember that in the first stage of labor, which is when they're dilating from 0 to 10 centimeters, right? Remember, there's 3 phases. There's an active phase of that first stage of labor. But when they're referring to active labor, they're actually referring to I think the second phase, which is delivery of the baby. Okay, active labor is delivery of the baby, not the active phase of the first stage. So just kind of just make that distinction, because that's a very easy way to get mixed up. So let me just say that. Okay. All right. So the question that they have was literally already kind of answered, so I don't want to ask that. Okay, I got it. All right, I got it. All right, so the first stage before I ask y'all questions, actually, this is important because I do remember this on my NCLEX, actually. What you also need to know, besides the stages of labor and how to identify it based on what exactly, like how it begins, how it ends, you also need to know the maternal characteristics, okay? You need to be able to identify what stage they're in just by their, not their actions, but their characteristics. All right, so I'm going to go back through it and just kind of read through some of the maternal characteristics that you should know and be aware of. All right. Now, remember, we said there's 3 phases of the first stage. Okay, and the first stage is dilation 0 to 10 centimeters. As that labor progresses, mom's going to act different. Okay, because as that labor progresses, the pain's going to get worse, depending on, especially depending on if they've had pain relief or not, if they're doing the natural way, or if they've had, what's that shot called? It goes into your spine. Oh my God, I'm having hysterectomy brain. What's the shot called? Yeah, that goes in your back to help with pain. It's on the tip of my tongue. Y'all know what I'm trying to say. Please, somebody say it. Please somebody comment it, because it's literally, I'm having hysterectomy brain so bad. Thank you, epidural. Thank you. Ha. So yes. So in the first stage, which typically lasts 12 and a half hours on average, but it is It moves faster once you've, like if you've had multiple children, if that makes sense. Because dilation moves on average for like at a pace of like 1 centimeter per hour. But if you have already been through childbirth, if this is like your second plus child, then it moves faster. Muscle memory. That thing has been here before. Okay, so it moves faster than 1 centimeter. It's actually about 1.5 centimeters an hour. So just know that. During the latent phase, which is the latent phase of stage 1, which is up to what centimeter? 0 to what centimeter is the latent phase? Latent phase is 0 to what? To 0 to how many centimeters? Just comment it real quick. 3, absolutely. 0 to 3 centimeters. All right. There may be some, during that phase, there may be obviously some dilation and effacement, which is what you want to happen. But since that's the beginning phase of that beginning stage of labor, it's not going to be as prominent and exaggerated as like you in the last phase. Okay. So just kind of just think about it. All right. You're about to give birth. Like you've spent the past 9 months or however many, leading up to this. Now we're going to talk about a normal childbirth. Okay. That's another thing, another tip. When you're taking your NCLEX, you are in, unless otherwise stated, you're in a perfect world. Okay. You are perfect. You have the perfect amount of staff. You are not short staffed. You have your favorite CNA. You have your favorite RN doctor. You have your favorite scrub cap on, your favorite shoes, the scrubs that like make your booty look big. Like it's a perfect world, honey. Okay, we just had lunch. It was good. It was catered. It's a perfect world in NCLEX. All right, perfect situations, unless they say otherwise. So what I don't want y'all to do, especially those that have had children, and that's where a lot of people mess up in maternity, okay? A lot of females mess up in maternity because they'll be like, that wasn't my experience giving birth. We're not asking you. Respectfully, you can't take your experience and make that Bible. Like, that's just not the way medicine works, nursing works, life. Okay, everyone's going to have different experiences. So do not take your own personal experiences and then apply that to whatever situation, whatever question you're reading, whatever situation you're reading and they want you to answer. So just know that. All right. So right now you have a normal birthing process. You're having a normal patient, no complications unless otherwise stated. It's normal. So how would you expect for a new mom to be at the beginning of labor? Right? At the beginning of labor. The pain has not set in yet because they're at the beginning. They're in the latent phase, right? They're in the latent phase. So there is no really, they're not in that much pain. Let me just say that comparatively. So you can expect them to be, I think somebody said excited before. Talkative and eager. Okay? If she's talking and eager and anxious, more than likely she's in that first stage. That first phase of the first stage. All right. Now, as she goes into the second phase, which is the active phase of that first stage, then, we're moving from 4 centimeters to 7 centimeters. All right. We're kind of halfway there as far as the dilation process. That's when it kind of starts to settle like, oh shit, like I'm almost there. So you can expect some feelings of anxiety, restlessness, as those contractions become stronger, because that dilation now is between 4 and 7 minutes. So literally you're just about halfway there. You are halfway there. So besides that, like, helplessness and anxiety, restlessness, as those contractions become stronger, then they kind of get introverted. They start talking less. Now they're kind of in their head like, oh shit, I'm about to be a mom. The pain's kind of getting worse. I don't want to cuss nobody out. Let me just shoot. So then they start, like I said, you expect them to become less talkative, less excited, and more nervous and introverted. Okay? And then we're going to go into the last phase of our first stage. All right? And that's in our transition stage. Okay? Now they are between 8 centimeters and 10 centimeters of dilation. So they're they're either almost or at complete dilation. Okay? How would you expect that they can't do it? Exactly. I'm saying, how would you expect for them to feel right when they get into like, oh shit, you're about to reach the top of the roller coaster. All right? There is no turning back now. There is no turning back now. So then it starts to kind of click and really, really get real. Okay? You expect them to be tired, restless, irritable. That's usually when, like in the movies, they'll be like, "You did this to me!" Like, shut up! And trying to feed her ice, like when the baby's father trying to feed her ice, and she's like, "You did this to me!" It's usually around that transition phase of the first stage. All right, they feel out of control. They often say, "I can't do this. I can't do this. I cannot do this. Like, I cannot continue to do this. Absolutely not." This is when the fetus starts to descend. Well, really, the fetus started to descend like in the active phase. But this is really when the baby's about to make its way through. What's up, boo? I am in here. I'm about to bust out. All right, so they're feeling like the urge to push. So a lot of times they'll be like, wait, not yet, not yet. You're not at 10 centimeters yet. But they're feeling that urge because their body is getting prepared. And they also feel that urge to have a bowel movement. It's typically around the time when they have the bowel movement. Just because that urge to push and the feelings of that heaviness it's increasing rectal pressure, which is why they always feel like, I gotta poop. Sorry. This is actually the most difficult part of labor. Okay? The transition phase of the first stage is the most difficult part. It's usually the most difficult part of labor. Okay? Now we're going to get into the second stage. All right? Now this is where the pushing begins. So if you see a mom pushing, then they're so clearly in the second phase. All right? Whenever pushing, especially of the fetus, all right? When you're pushing out the fetus, you're in the second stage. All right? When you're pushing out the placenta, you're in the third stage. Okay? Now, remember I talked about as the future nurse that you're going to have to record and observe what side of the placenta is presented during like expulsion. So remember, there's two components of the placenta: a smooth side and a rough side. Okay, I'm just go through it. Smooth side and a rough side. The rough side is the side that looks like a tree of life. Okay, it's the one that like literally has like the branches. You can call it the branches. It looks like the one that like a whole bunch of branches on that side stemming out of the umbilical cord. So that side is the fetus or the fetal side, and then the smoother side is the maternity side. Now there are actual names for the sides, but when you're recording which sides comes out, it's a little different. So let me go back to the placenta. All right, so the fetal part is the amnion. All right, that's, like I said, that's the one that looks like a tree. Okay, the amnion is the fetal side. And the maternal side, which is the smooth side, is the decadua. I hope I'm pronouncing that right. I know it if I see it, but I don't know if I'm pronouncing it right. I hope so. But yes, so when you are noting which side comes out, if the fetal side comes out, or the amnion part of the fetus, or the part that looks like a tree of life with a whole bunch of branches, if that part comes out first, then it's called a Schultz presentation. Wait a minute. Schultz presentation. Boom. All right, so that's the Schultz presentation. That's the shiny fetal surface of the placenta emerging first. Okay, now the Duncan side. Duncan, not donuts. Okay. The Duncan presentation is the maternal side. Boom. Oh. All right. The dull maternal surface of placenta emerges first, then it's Duncan presentation. If the shiny fetal surface, which is the rougher surface that looks like tree branches, or tree roots, I should say, that one's the Schultz presentation. So make sure you kind of know that. All right. And like I said, that's the third stage, because if you are observing for which side of the placenta is coming out, that means you're in the stage of placenta delivery, which is the third stage. Okay, so you got to know what's included in each stage, because the questions that they ask you won't be as like black and white as which stage has this. No, it's not. It's never going to be that easy. And then the fourth stage, remember, that is the postpartum and the stabilizing. Okay. At this point, all the action has been had. So we're waiting for, we're trying to achieve homeostasis again. All right. We're trying to have our bodies, our vital signs, everything go back to like a normal baseline. Okay. So that stabilizing phase, same thing. We're waiting for those vitals to be stabilized, and we're observing, all right, and monitoring for those vital signs and everything else about both mom and baby to be stabilized. Okay. And then this is also the phase that as the nurse, you're going to be observing and recording the amount of discharge. Well, not I won't say discharge, the amount of lochia, which is the bleeding post-delivery. Okay. There's specific like colors, amounts that's normal and supposed to be almost to be expected after delivery. Just like, you're expected to bleed after surgery, you're expected to be bleeding after you push like an 8-pound human being out your hoo-ha, okay? So we're, as the nurse, you're observing just to make sure that there isn't any like excessive bleeding going on. Make sure there's not like an infection, a weird smell, a odor, or anything like that. So that's what you're going to be, as a nurse, that's what you're going to be assessing for. Okay. Now, there's 3 types of lochia. All right. And it depends on the color, and how long it lasts depends on, I guess how long it's been, I should say. The color depends on how long it's been. All right. So, like I said, there's 3 types of lochia. All right. Lochia rubra. All right. RUBRA. Kind of looks like ruby. When I think of rubra, I think of ruby, like a ruby red. That's going to be like a dark red, ruby red, right? That typically lasts about 3 to 4 days. Okay, so if you're like coming up on like day 10 and you still have this dark red, and you still notice this dark red bleeding in the pad after birth, something's not right. Okay, that dark red, ruby red, rubra, let that kind of help you. Should be 3 to 4 days. Okay, lochia serosa. All right, that one's more of a brownish pink. All right, not as dark as a dark red, but not more blood tinged, almost like that. It's a brownish pink. All right, almost like I don't know. Well, hopefully everyone here is a female that's had their cycle. But like, you know, when your cycle's about to go off, and you got that weird annoying brown, a brown pink. It's like not off, but it's not on. Like that purgatory of your period. Yeah, that. Lochia serosa. All right. That's a brownish pink that lasts for 4 to 10 days. Okay. As time goes on, that color should be getting lighter and lighter and returning to normal. Okay, should go from dark red to like a brownish pink. And then the third one is Lochia alba. Okay, that is a whitish yellow. When I see alba, I think about albino. Which helps me, okay, it's the lighter one. It's the lighter one. This is expected 10 to 28 days after giving birth. Okay, it's like a whitish, pale yellow. I would say that, like a whitish pale yellow, not a infection yellow or yellow green. Absolutely not. So like a whitish yellow is Lochia alba, 10 to 28 days. Okay. All right. Let me see. All right, so we just talked about pelvises, stages of labor, pregnancy complications. We're good? Are we following along? Are we following along? Thumbs up if you guys are good. If y'all have any questions, please just ask them. And well, even if I don't know it, we're gonna look it up together. We're gonna learn something new together. Okay. Like I said, let's get into pregnancy complications. Okay. Now there's quite a few things that can happen that can complicate a pregnancy. Okay. And it depends on when in the pregnancy those complications happen. Is kind of how you term those. All right. Things can happen. You can have complications like postpartum after you give birth. You can have postpartum complications. You can have complications during actual labor and delivery, and you can have complications prior to. All right, you can have complications like in your prenatal period. All right, so let's go ahead and get into I'm trying to figure out which complication I want to start with. Or what? Yeah, okay, let's do that. Okay, so let's go ahead and start with complications that can occur before labor. Okay, so like prenatal complications. Let's go ahead and start with that. All right, so when you're learning complications about labor, what you definitely want to remember is that with maternity nursing, you're not just worried about the safety of mom. You're worrying about safety of mom and baby, that's part of the reason why some of the questions that they're asking you within maternity nursing, like that's why you see a lot of people saying, okay, there's a specific way that you need to study for maternity nursing because of that fact. Especially because usually when you're taking maternity nursing, it's usually like halfway or when you're almost finished with your program. It's definitely not one of the initial classes that you take within like your first semester. So, you know, this isn't your first type of nursing school exam, if that makes sense. This is your first nursing school course. So the way that you've been learning through trial and error how to answer these like NCLEX style and nursing school questions about all these other classes, you're gonna take that with you into maternity nursing. But there's a slightly different way, like I said, that you need to answer these questions simply and just off the strength on the fact that you're not just caring about the patient. Your patients are mom and baby. So sometimes what you need to do for mom can be risky to the baby and vice versa. So you have to be aware of that to make sure that both of your patients, you're doing what you need to do as far as your client safety when you have two clients in one. That makes sense. Okay. So there's a few things that like a few conditions that can risk pregnancy before you even get to the whole labor part. And these are certain things that they tell you like not to do, foods they tell you can't eat, things you can't do, and then other things to look out for that could pose a risk to the pregnancy. Okay, now conditions that can risk pregnancy. Placenta previa. Okay. Preeclampsia, eclampsia, hypertension, avoid torch infections. Absolutely. But we're gonna get into that. But conditions that can actually risk a pregnancy no matter what stage of that pregnancy is in. First one is placenta previa, and you definitely need to know this. Okay? Yes, we're gonna get into the things that you definitely don't do, because I see those specific things come up all the time when doing NCLEX Jeopardy. So that's why we're doing this review, because we're gonna talk about it. All right. First thing I want y'all to know, because it's asked all the time, I need you to know the difference between placenta previa and abruptio placentae. Placentae. All right, let's start with placenta previa. PP. Okay. A lot of people will get placenta previa and abruptio placenta mixed up, but there's certain specific characteristics and manifestations in each of those. All right. Which one's going to give you, wait, hold on. Let me actually never not say that. Which one's going to be painful? Placenta previa or abruptio placentae? One's going to be painless. One's going to be painful. So what did I ask? Which one's going to be painless or painful? I can't remember which one I said. I'll say painful. Which one's going to be painful? Between placenta previa, just put PP, and abruptio, which one's painful? Abrupto, whatever. Yes, abrupto placentae. That's going to be the painful one. The painless one's going to be placenta previa. Right. So, how I remember it, placenta previa, painless. PPP. Not the PPP loan, the PPP placenta complication. Placenta previa is painless. All right. It's also going to give you bright red bleeding. Okay, you're gonna get bright red bleeding with placenta previa. So you get painless, bright red bleeding. All right. For abruptio placentae, you're gonna get the vaginal bleeding. Both of them obviously you're gonna be bleeding. One's just gonna be painless with a different color blood. Abrupto placentae is going to be a little bit more darker. All right. You're going to get abdominal pain. You're going to get uterine irritability, uterine contractions, and that usually can result in fetal death. So it can definitely pose a risk to both mom and baby. All right, now placenta previa, that painless bright red bleeding, what's gonna be the actions, I guess you can say, the treatment and the nursing considerations. Treatment's going to be aimed at replacing blood loss. Okay. The vitals are going to, because of that bleeding, it's going to be, that bright red bleeding is going to be almost like hemorrhage, almost like hemorrhaging. So you're going to, your vital signs is going to give very much shock symptoms. Okay, it's going to reflect the vitals of someone that was actually in shock from blood volume loss. Okay, because that blood volume is lowering, and we know if the blood volume lowers, the mom's heart rate is going to be affected. And if mom's heart rate is affected, baby's heart rate is affected. Okay. So monitoring, obviously vital signs are going to be monitored for the mom, but specifically fetal heart rate needs to also be inspected. Okay. Now, this is very important. Placenta previa. Are you going to want to do a vaginal exam? Yes or no? Yes or no to vaginal exams on someone who has or could possibly have or suspected to have placenta previa? Are you doing a vaginal exam on someone with or confirmed or suspected placenta previa? No. Why? Well, I'll ask that one. Well, can anybody tell me why? Can anybody tell me why you are avoiding vaginal exams? Thank you, pretty green eyes. It could cause further hemorrhaging. Absolutely. So this is what placenta previa even is. Okay? That is placenta previa is when the placenta is attached to like the cervix, near or over the cervix, and that's abnormal. All right, so it's abnormal attachment of the placenta, and which is obviously in the uterus, near or over the cervical opening. Okay, so if that abnormal attachment, that placenta is near the cervical opening, and you go to do a vaginal exam, there's a very high chance that you just make that thing worse. Okay. Now there are different types of placenta previa. It can either be total, partial, or marginal, just depending on how much of that cervical opening is obstructed by the placenta. So let's say this is my cervical opening and this is my placenta. All right, it was over the whole thing like that. This is total placenta previa. It's totally covering that opening. Now, if it's to the side a little bit, okay, if it's to the side a little bit, it's partial. All right. Now, if it's more of an opening and it's not, if it's more against the, let me just say, if it's not as covered as partial, and it's definitely not completely covered, it'll be marginal. It's marginally covering the cervical opening. Okay, so that's the difference between total, partial, and marginal placenta previa. Okay, placenta previa equals painless, bright red bleeding. Okay, do not please avoid vaginal exams. Okay, when it comes to I won't say that. I already talked about abruptio previa, that one, but I'll tell you what that one actually is. Okay, when you're thinking about the actual signs and symptoms of placenta previa, you can remember it by the acronym previa. Use previa. The P in previa stands for painless, bright red bleeding, painless and profuse, which means a lot. Bright red bleeding. The R stands for relaxed, soft, and non-tender uterus. Okay, now, and that's where this is where that comes in. When you hear someone describe a uterus as boggy, B-O-G-G-Y, a boggy uterus is an enlarged, soft, and tender uterus. Okay, and that's usually identified during like a physical examination, blah, blah. You do not want your uterus to be boggy. I had a boggy uterus, and that's because it's commonly caused by adenomyosis, all right, which is a form of endometriosis just within the walls of that uterus. So you do not want a boggy uterus, all right? You want it normal sized, you want it non-soft and non-tender, okay? If something's tender, that means there's some pain going on, and pain is not normal, okay? So whenever you're doing your physical assessment or even charting with maternity patients, they're going to want you to definitely chart on or make mention of the assessment of the uterus. And it's going to ask you, is it a boggy uterus or is it non-soft, non-tender, normal sized? So when you see the word boggy, it's bad. Okay? you definitely want it to be non-tender and non-soft. All right? So a symptom and a sign and symptom of placenta previa is a relaxed, soft, non-tender uterus. So it's not boggy. All right? Placenta previa is not boggy. But that just helps you make your differential, or make the providers make their differential diagnosis. All right? You know, if you do have bright red bleeding, but you do have a boggy uterus, then you know, okay, this is more so, this could be something else. Because remember, the bleeding is painless. So you can't have a placenta previa and a painful uterus. Does that make sense? Because once again, it's painless. So asking if it's painful or painless can make the difference, can actually be the deciding factor between whether you or a provider wants to explore placenta previa or another differential diagnosis. So all these assessments, they matter. They mean things. Okay? So P for painless, R for relaxed, soft, and non-tender uterus. The E is for episodes of bleeding that's not spotting. Okay? Especially during the third trimester. Bleeding during the third trimester that's not spotting is usually abnormal. Okay? And what's the next one? V is for visible bleeding. Okay. Visible bleeding is also going to be the thing that helps to differentiate between placenta previa and abruptio placenta. Because with abruptio placenta, a lot of times that bleeding is concealed. Okay. If you're visible bleeding, like that hemorrhaging, you're gonna be visibly hemorrhaging outside. Really, for abruptio placenta, that's really it's gonna be It's dangerous for abruptio placenta because you're bleeding on the inside. You don't see it. It's a silent killer, basically. So V is for visible bleeding. I is for intercourse post-bleeding. Actually, I wouldn't say. Yeah, sure. Yeah, intercourse post-bleeding, which is spontaneous or during labor. That can be an I. My personal I is for inspect fetal heart rate. That's my I, because I feel like we've already covered bleeding, so I wouldn't want to make that I something else the same. That's contributing to the bleeding that I feel like we've already covered. But paying attention and inspecting that fetal heart rate, it just is just as important in placenta previa. So my I would be inspect fetal heart rate. And then the A would be avoid vaginal exam. Okay? So previa, painless bright red bleeding. R is for replace blood loss. E is that it's evident, that bleeding is evident in lower areas. V is for vitals, I'm going to point to shock. I is for inspect fetal heart rate, and A is for avoid vaginal exam. Okay, no abdominal manipulation and no vaginal exams. All right. You're watching for bleeding or risk for hemorrhage. So whenever you're doing like your care plans, okay, when you have to think about these nursing diagnoses, if anything that's involving bleeding, hemorrhaging, give me an example of a nursing diagnosis. Remember, hemorrhaging is not a nursing diagnosis. It's a medical diagnosis, which as nurses we cannot do. So we have to take what's the medical diagnosis. You have to take that and then associate that with a matching nursing diagnosis. What would be a nursing diagnosis for a patient that's at risk for hemorrhaging? Does anybody know? Does anybody know? No, because hemorrhaging and excessive bleeding, that's still a medical diagnosis. Fluid volume deficit. Thank you. Fluid volume deficit. Absolutely. And fluid volume deficit is like a universal nursing diagnosis that can mean any type of fluid volume, whether that's like water content, like if someone's dehydrated, fluid volume deficit would be the nursing diagnosis. If that fluid is blood and they're bleeding out, fluid volume deficit. You're picking up what I'm putting down? So make note of fluid volume deficit, because sometimes you will have questions and they're asking, what would be the priority nursing diagnosis for this patient that's been diagnosed with placenta previa? You got to remember your ABCs, airway, breathing, circulation. When it comes to bleeding, that's definitely a circulation issue. So if that patient does not have any airway or breathing issues, then bleeding out is definitely going to be the next most priority thing to go after. So yes, fluid volume deficit, make sure you kind of put a star to that one. Okay. So that's placenta previa, and we talked about abruptio placentae and the difference between those two. Okay, let's talk about prolapsed cords. Prolapsed cords. Mind you, these conditions that I'm telling you about, there are conditions that risk pregnancy, but I'm mentioning these specific ones because during your exams and on the NCLEX, what you need to focus on is like your nursing actions, your interventions. They're the whole point of nursing school and NCLEX is to assess you and make sure that you are competent. You are a competent nurse. You know what to do in any situation. So whether it's this NCLEX or the new NCLEX, what they're doing, what those questions are going to be doing, going to be assessing for, despite how they ask you and what different like alternative format they ask you, they're asking whether or not you know what to do. They're trying to see if you know what the fuck to do. So prolapse cord. So a lot of these are going to be very nursing intervention heavy. So like I said, first things first, it's great that you know the difference between abruptio placentae and placenta previa. It's great that you know the difference between that, girl. It's amazing. However, these nursing exams and the NCLEX is specifically wants to know, okay, now that you know the difference between the two, do you know what to do? Do you know which one is the one that you do not want to do a vaginal exam? So anything that's directly affecting you and your actions, like knowing this piece of knowledge is going to definitely affect your nursing interventions and your nursing actions, that's what they're going to be assessing. So pay attention to any of that stuff. Yes, my material is used for RN programs. All this information needs to be known by nurses, period, whether it's RN or LPN. I had to learn this stuff when I was in LPN school. And as an RN, you're going to learn this stuff as well. Okay? Prolapse cord, all right? Now, what you need to know about a prolapse cord, how it affects, remember, you need to figure out how it affects mom and baby. Remember, with abrupte placenta and placenta previa, how did that affect our patients? Both of us, both of them, mom and baby. That bleeding is going to cause mom's going to bleed out, which is going to then cause baby to not necessarily bleed out, but not get the nutrients or oxygen needed to go on living. So prolapse cord, how does that affect our mom and baby? Okay, it causes variable D cells. Okay, it causes variable D cells, and whenever you hear D cells, especially within maternity, they're talking about deceleration. Okay, and that has to do specifically with the fetal heart rate. All right, decelerations, kind of let the word help you. When you have accelerations and decelerations, right? So when you decelerate, those are temporary, especially variable decelerations. It is a temporary drop in the fetal heart rate. Okay, decel, going back, dropping in the fetal heart rate. All right, you can either have early decels, late decels, or variable decels. And a prolapse cord can cause variable decels. All right, now of these decels, early, late, and variable, which one is normal? Which one is normal? It's important to know this as well, because you will get a question saying you're looking, as the nurse, you're looking at the fetal heart rate monitor and you noticed blank decels. What's your next action? What is the priority nursing action for you to do? You're going to have options where it's asking you to do something or to note that it's normal and document it. And you have to figure out, like, oh shit, which one is this normal or is this not? So you have early, late, and variable. Which one is normal and not concerning? Note this, okay? Early decelerations are actually generally normal. Thank you, Daniela. Early decelerations are generally normal and not concerning. Okay, late decels and variable decelerations, that's usually a sign that the baby's not doing too hot. Okay, just think about what decelerations are. Temporary drops in the fetal heart rate. All right, if you have late drops in the fetal heart rate, and also variable ones, like consistently inconsistent, however you want to describe variable, those are bad. Those are bad. All right, so early is definitely the decelerations that are generally more normal. Make sense? Know that. Know that. Early is the exception. E for E. Early is the exception. It is not a bad thing. Okay? All right. Now let's go back to prolapse cord. All right, so prolapse cord causes variable decels, which we just discussed that variable decels are one of the bad ones. Late and variable, bad. Okay? So when you have a patient that comes in presenting with signs of a prolapse cord, or just after they've been officially diagnosed with a prolapse cord, these are the things that you as a nurse, you need to do. Okay? Well, this is what you need to know. All right? Once that prolapse cord is exposed to air, it dries out. Now think about what a prolapse cord is. You know how people be like, oh, I got a prolapsed uterus, prolapsed rectum, anytime you see prolapse, that means it's fallen out of where it's supposed to be. Like a prolapsed bladder, and then you need like a sling to hold it up. A prolapse cord, that cord then fell from where it was supposed to be, okay, and is now like protruding out, basically. That cord is now hanging from your hoo-ha. All right. Now what's the actual? Okay. So yeah, a cord prolapse is when that umbilical cord slips through the cervix and into the vagina. And that usually happens after a mother's water breaks. And it happens before, like, it's time for the baby to come out. So whenever water breaks, that's why it's always like, that's why the teaching is always like, whenever you feel, whatever you think that your water has broken, you need to go straight to the hospital. You need to go straight to your birthing suite, straight to the little kiddie pool. Girl, I don't know where you having labor. I don't know where you giving birth, but you need to go. You need to go now, because after that water breaks, then, that's when pretty much you go into that first stage of labor. We just talked about it. Go to the first stage of labor. Their body's preparing itself to expel this 8-pound, however many pound baby out your body. Okay. So then your body's going to naturally have that baby be, descend. And if the water breaks, and if that water is going to be that thing that kind of keeps it in, that water breaks, so that cord, think about that cord like this. This is the opening of your hoo-ha. That cord coming out like that. Okay? And whenever you see this cord, there's a baby attached to it. Okay? So that cord's going to come out, and that baby's going to slip out too. All right? So, what you have to remember is that when this cord, though, when it hits air, y'all was here yesterday, right? What's the umbilical cord made of? What is the substance that the umbilical cord is made of? What is the substance that the umbilical cord is made of? Wharton's jelly, absolutely. So when that jelly, okay, that once very moist cord is exposed to air, it's gonna dry out. Okay, it drying out can cause a whole slew of problems. So what you want to do to avoid that cord drying out is, as the nurse, what you're going to want to do, well, it's a couple things actually. All right. You're going to want to cover it with a sterile saline dressing. Okay, cover that cord, especially if it's coming out. But also, first of all, anytime there's an umbilical prolapse cord, you about to give birth now. Okay, you're about to give birth now. And as far as giving birth, are they going to give birth vaginally or need a C-section? For a prolapse cord, no matter when that happens, whether it's 40 weeks or whenever, maybe too early, doesn't matter. Whenever, if ever it occurs, immediate delivery is needed. However, what kind of delivery are they going to need? Vaginal delivery or C-section? Prolapse cord, what kind of delivery? Are we delivering vaginally or C-section? Prolapse cord, when that happens, are we delivering vaginally or are we getting a C-section? C-section. A C-section is needed before those membranes rupture. Absolutely. Okay, the route of delivery is usually via a C-section. Okay, now why is it so pertinent that we that person delivers immediately via C-section? All right, think about the purpose and the function of the umbilical cord. All right, that is the cord that delivers nutrients, oxygen, blood, all that good stuff to the baby. So it's essentially like the baby's lifeline, quite literally. I don't know if visually, think about this. Have you guys ever played outside when you were children and played outside by like the water hose? Like that green old school water hose? And then you took that water hose and then did this. Y'all know what I'm talking about? When you take that water hose and do this, cutting off the flow of that water hose. Y'all remember that sensation? Y'all remember what happens? Obviously, there's no more water coming out. But that it also kind of like backs up right here. Okay? So that cord compression when it's prolapsed, because remember that it's coming out of that cervical opening, it's going to stop delivering all the good nutrients to that baby, which can, once again, cause harm to that baby. So usually, whether it's the nurse or the doctor, honestly, whoever, what's being done in addition to keeping it moist is to keep pressure off of it. Okay? They have to actually digitally, manually raise, like they have to keep that like elevate that whatever it is that's compressing. Usually it's the fetus. So what they have to do is usually like go in there with their 2 fingers, hand, whatever, and lift and like I said, manually elevate that part of the fetus that's compressing the cord, so it doesn't basically do this to it. All right, you don't want to compress that cord. You want to lift up and keep as much pressure off of it to keep it so that it's not compressed, and cutting off flow of any of the nutrients, oxygen, blood flow that's going to the fetus from the mother via the cord. Okay. All right. So that is, like, once again, that is usually an emergency. Okay. And that's one of the things that a mother is educated on, especially closer to due dates. They're educated that whenever their membranes rupture, to go straight to the hospital, okay? So they can avoid infection, all right? B, if their cord does prolapse, especially before their membranes actually rupture, that can cause variable D cells, which we already talked about is bad with the baby. So then we got to cover the prolapse cord with a sterile saline dressing or a compress, and then elevate that cord or elevate whatever is compressing the cord so that we can continue on with delivery, which is, like I said, usually by C-section. So usually that person like jumps even with their like fingers up in there, okay, keeping it off the cord. They have to hop on the stretcher and just kind of just ride as they continue on lifting. You gotta lift it. You gotta do what you gotta do. So there is that. Another complication or condition that can happen is uterus inversion and uterus rupture. Okay. Uterus inversion is when the uterus turns inside out during delivery. Ooh, can you imagine? Ouch. All right. So like kind of like turning. That's bad. So what you want to do is you want to avoid applying too much pressure when removing the placenta or the fetus, so you can avoid uterine inversion. Because remember, that cord, it's connecting the fetus to the placenta. All right, and the placenta is attached to, it's a temporary organ within the uterus. So if you are removing that placenta or trying to help that placenta be expelled after delivery, applying too much pressure and tugging a little bit too hard can cause the uterus to just flip inside out. That's bad, and it'll be your fault. Don't do it. All right. Question: if ever you're in a situation and uterus inversion does occur, do you want to replace that inverted placenta? Do you want to just put it back? Yes or no? Are you replacing the inverted placenta? Are you replacing that inverted uterus or placenta? Do you want to replace it? Yes or no? Are you replacing the inverted placenta during uterus inversion? The answer is no. Okay? You never want to replace the you never want to replace the inverted placenta. That's just a big no. Okay? You also need to know the common reasons for a C-section. Okay, we talked about umbilical cord prolapse. We talked about well, we really didn't talk about that, but these are all the things that will require it. Umbilical cord relapse. Well, we did cephalopelvic disproportion, or CPD. All right, what that basically means is that the mom's pelvis and the size of the baby's head is not proportionate. That big old head is not coming through the type of pelvis that you have, Miss Ma'am. So when that happens, cephalo, which means head, that prefix means head. Pelvic, remember there's 4 types of pelvises. Disproportion. This, this is like trying to fit a square through, no, a circle through, a square through a circle, a circle through a square. One of them, child. But yeah, it's not working. It's not happening. So cephalopelvic disproportion is when the fetus's head and the mom's pelvic, it's not proportionate for a vaginal delivery. So C-section would have to happen. That's also another thing that can also cause C-section is like when that baby's in breech, when the fetus, baby, whatever you want to call it, is in a breech presentation or breech position. Now there are 3 types of breech presentations. All right, complete, frank, and footling. Okay, and I'm gonna show y'all literally physically show y'all what it looks like. All right, now this is the first breech presentation. This one's called a complete presentation. All right, I'm the baby presenting as breeched. Okay. All right, y'all see me? Y'all see me? Crisscross applesauce, complete. That's a complete breech. Okay, so how am I supposed to, as the baby, how am I supposed to be delivered butt booty first, right? I'm supposed to be upside down. I'm supposed to be coming in like that. But no, whenever the fetus is like in a inverted position, aka kind of like the head's kind of up and the feet's down first, it's called the breech. All right, now the legs are literally crossed, like crisscross applesauce. It's a complete breech. Second type of breech, I'm not flexible enough for this, but both of my legs up. You know how you put your, like, if speaking of babies, but you know how you lift like a baby's legs up, both of them, to kind of wipe, and both of their feet just kind of in the air as you hold it. Imagine their feet right here, and then like they just like this. This is my foot, and it's like that. That's a frank breech presentation. All right, legs up as if you're about to like wipe a baby's butt. Legs up, breech down. I don't know. And then the third type is footling. Let the name kind of help you. Footling is almost just like complete, except for the fact that they have literally one foot hanging out. They just, like, you know when you sitting like next to the pool and you kind of like this, but you have one foot in the water, kind of just, that's footling. They're putting just one toe out in the real world, trying to see if they like it or not, so they can climb back up like, this world is way too ghetto for me. I'm going back in. That's footling. One foot hanging out. Okay. Now, whenever there's a certain maneuver that you should know about, that's done that can actually determine the breech presentation. All right. Whenever you have a question like maybe like suspected breech, the provider, maybe the nurse or whoever suspects a breech, how do you expect for the provider to determine that breech presentation? All right, there's a specific maneuver. Do y'all know what it's called? Do y'all know the certain maneuver that determines breech presentation? If you don't, make a star, because that's exactly what the question will say. What maneuver can determine breech presentation? In addition to like obviously a vaginal exam, but what maneuver within that vaginal exam can determine breech presentation? Does anybody know? If you don't, that's fine. Just put, girl, I don't know. What kind of maneuver can determine breech presentation? Anybody? That's fine. Leopold. Please make a note of that. Leopold's maneuver. Sounds like a really old king. King Leopold. Leopard man. That's funny. Leopard man, but Leopold is his name. But that just lets me know if you see the name, then you be like, it looks like Leopold. Leopard man. That's funny. But yes, Leopold's maneuver plus a vaginal exam can determine breech presentations. Now, after a breech birth, all right, you want to assess for injury. She was close, right? Period. You want to assess for injury. Okay, I don't know if y'all have I've never had a baby or been through childbirth, but I've seen it. Not just in movies, but actually during clinicals. Y'all go through a lot. Y'all go through a lot. There's a lot of trauma that happens, whether it's C-section or vaginal. There's a lot of trauma. So, assessments to both baby and mom afterwards is very important. Specifically, if the birth was a breached birth, then you want to assess for specific types of injuries. So, usually with breech birth, because I feel like, okay, sure. Let me just say this. Usually with breech birth, as the injury that you are looking at, or the most common types of injuries with breech births is fractures, hematomas, and then others that are caused by the trauma of the birth. Okay. Now, what you do want to be very aware of is cord compression during those breached births, because their positioning is not ideal where they're supposed to be as far as giving birth. Sometimes the way that they're sitting, or sometimes what they're sitting on can be the actual cord. And we just talked about anytime that cord is compressed, just like a water hose, and you do this to it, all the nutrients and everything that the fetus is getting from the umbilical cord stops, okay, including oxygen. So that can obviously lead to fetal demise. And that spontaneous pressure change can also cause intracranial hemorrhage as they're coming out. Like I said, especially if they're in breached positions. It can actually cause a brain bleed. So that's something that the nurse, you want to assess for. Another type of complication for pregnancy, and I definitely want to hit on this before we go, is preeclampsia/eclampsia. Super important to know, both as a nurse and a female. Okay, preeclampsia. When you think about preeclampsia, there are three. They call it the preeclampsia triad, which is three like main symptoms, main signs hinting towards preeclampsia. Okay, this is stressed to future mothers, so they know that, hey, if you notice this, if you notice that you're feeling this way, or if you notice these specific manifestations, you need to go get checked out, because this is what it could be. And if you have that, then you need to definitely seek immediate medical attention. So preeclampsia. Does anybody know? I'm going to say it. The triad is PIE. P-I-E. P-I-E. This is how I remember it. The P stands for proteinuria, or protein within the urine. The I stands for increased or increasing BP or hypertension. And then the E stands for edema. Okay, now when we come to edema, this is very important because they love to try to get y'all with this. Edema is very specific, especially related to like a specific disorder. The edema is very specific in itself. Okay, so whenever you see edema specified, it means it's specifically that type of edema. So for example, whenever you see generalized edema, that is not the same type of edema as this. Okay, the edema that you can expect to see specifically in preeclampsia or eclampsia, the edema is usually around the face and around the orbital region. All right, this is where you're going to see the edema. Generalized edema, where it's literally just generalized all over your body. It's not a specific, like, there's no area of your body that's specifically hit worse than the other. It's just generalized. You're just swollen all over. It's something a little bit different. Okay, but you can expect for edema to be noted in preeclampsia patients around, it's called periorbital edema. All right, so around the face and around the eyes. That's going to be the edema that you really see. Okay. Now, as far as edema, like let's say you have a question that says like lower extremity edema or edema in like the legs or something like that. It's typically a common occurrence with pregnancy, right? My feet so swollen, blah, blah, blah. You know, that hands, feet, ankles, that type of edema is usually just from water retention, which is a normal part, unfortunately. Normal part or normal expectation of pregnancy. However, with preeclampsia, the specific periorbital edema mixed with the protein in the urine, mixed with the elevated blood pressure, that's what's going to make it like indicative of preeclampsia. Does that make sense? So how come it's in the face? That's a good. I'm trying to see, like, why exactly? Why? Swelling. It doesn't really just say why. It just really just makes that distinction. This is while some swelling is normal during pregnancy, large amounts, and we're not talking about just a little bit, like noticeable amounts, large amounts of swelling in your face, primarily around your eyes or in your hands, can be a sign of preeclampsia. Okay. So yeah, that's definitely. Now, if you just have swelling in your face without the other, like without the proteinuria or the increased hypertension, then that can be something else. But that's why that triad is a triad. All right. You need to have one. You need to select all that apply. You need to have all three in order for that to actually be cause for concern, if that makes sense. Okay. Now, as far as that protein in the urine, all right, preeclampsia, that can change the way your kidneys function, okay? And when your kidneys, P is proteinuria, as I've talked about right now, proteinuria, protein in the urine. When your kidneys aren't working the way it should be working, the protein starts to spill over into that urine, okay? They usually, like during your prenatal visits, checking for protein in the urine with little dipstick tests. That's typically what they're doing at like your OBGYN, like prenatal appointments and stuff. But they're also assessing for any types of signs of preeclampsia, like I said, being protein in the urine. So that little dipstick is just one easy way to be proactive rather than reactive into monitoring, as far as monitoring for preeclampsia. And then I said I for the increased hypertension, right? Yep, absolutely. The hypertension. Let me see what else saying. You're welcome. Okay, but yeah. So that was that. What else did I definitely want to cover today? Oh, since we talked about late D cells and the D cells period, now which of the D cells were normal? Early, late, or variable? Early, late, or variable? Before we go, I'm gonna teach y'all a little mnemonic to help y'all decide which one. But which fetal heart rate is normal? Early. Now let me say this. Okay? Okay, yeah, that's fine. Remember, you have accelerations and you have decelerations. Accelerations are the ones that are, obviously, they're fine. Those okay. But between variable, early, and late, early is the more normal one, the one that's not as much of a cause for concern. I wouldn't say it's all the way normal, but it is more normal than the other ones. And I'm gonna tell y'all why. So when it comes to fetal heart rate, you want to think about the mnemonic VEAL CHOP. VEAL and then CHOP. And when you're writing this mnemonic, literally I want y'all to write it in 2 columns. Oops. All right. So veal, not pork chop, veal chops. Okay. So let's go ahead and write it together. VEAL in 1 column, and then chop in the next column. So you want to line them up. You want to line the V with the C, the E with the H, the A with the O, and then the L with the P. So it looks like this. Got it? All right. Now this is for fetal heart rate, okay? So now that you have your VEAL CHOP written, this is what they stand for. All right, so that first column, the VEAL, all right, that's gonna tell you the type of heart rate change. Okay, and then the CHOP is gonna tell you the possible causes. Okay, VEAL, type of heart rate change, CHOP, possible causes. You got me? All right, so let's go by let's go through it one by one. All right, so the V in VEAL, the V is going to stand for variable D cells. Variable D cells. Okay, now when we come over to the possible cause, that C is going to stand for cord compression. Cord compression. Just like we talked about the prolapse cord, remember? The prolapse cord that causes variable D cells. So the V in VEAL is variable D cells, and the C is cord compression. Remember, the intervention for cord compressions is to elevate whatever it is that's compressing the cord. to elevate that and go to for delivery, usually C-section. Okay. Then let's go the next one down. The E is going to be for early decels. Okay. Early decels. The H, head compression. Okay. Remember I said that the early decels were definitely not as concerning as the variable or the late. Okay, to help you remember that it's better to be early than late. And that's why I said it's not necessary that early decels are completely normal. But it's better to have early decels than variable or late, if that makes sense. Does that make sense? Y'all see what I mean? So if you have a question where it's asking you which one is not so much of a priority between early decels and strictly talking about decels, early decels, late decels, and variable, early is going to be the less of the two evils, or the three evils. Okay? So early decels, possible cause could be head compression, but that's also like easily, you can fix that. Right? You can fix that. Next thing, A. The A in veal is going to stand for acceleration. All right, remember, deceleration is that temporary drop. Acceleration is that short-term increases in fetal heart rate. Okay? So just like accelerate, like when a car accelerates and it increases that speed, same thing with heart rates. Accelerations, and then the O right next to it stands for okay. Accelerations are okay. All right. And then the L stands for late decels. And the P right next to it stands for placental insufficiency. Veal chop. All right. So this is going to help you remember the types of heart rate changes, fetal heart rate changes, and the possible causes of those fetal heart rate changes. All right. Veal chop. I'm going to make a post about this, but this is also within the maternity study kit, which is why I told you I need to get it. Okay. Now, as far as what you should do when you do notice late decels. Okay, remember, it's better early to be late, but when you're late, you're messing with fate. I was trying to think of something, but it did not work. All right, so this is what you want to do intervention-wise whenever you note late decels. Okay, you want to tell that mom to be on which side do you want to lay? Left side or right side? Late decels. Do you want that mom to lie on the left side or right side? How do you want that mom to lay? Left. Want to lay on the left. You want to lay on the left. Okay, and do you know why you're laying on the left? I'm going to tell y'all why. Left lateral. It's specifically, like they're laying on their side, right? But they're on their left side, and they're laying on the left side specifically because what you're trying to do remember, late decels, if you look at veal chalk, late decels are caused by placental insufficiency. Okay, so what you want to do, especially if the cause is placental insufficiency, you want to take that pressure off of whatever it is. Okay, so what you want to do, you want to lay on the left side because it takes pressure off of the vena cava. Okay, from NOLA to Cali, takes pressure off of the vena cava. All right, and it actually allows for blood to flow to the heart and to the lungs. So lying on that left side is definitely going to be one of the first interventions for late decelerations. All right, now note this, because remember, whenever you have priority questions, ABCs, blah, 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 they're going to give you options that are correct. They're not going to give you incorrect options. That's way too easy. You can't have, hey, what should you do with someone with late cells? And one's like, turn on Netflix, lie her on her right side. Like, it's not going to be that obvious. Usually when it's priority questions, they're giving you all the right answers, but they're asking you not to choose which one is right. They're asking you to choose which one you should do first, which one is priority into making sure both mom and baby are safe. All right. And the first thing you should do with late cells is reposition. Okay. That's something, first of all, you always want to go from the least invasive to the most invasive. All right. Repositioning, you don't need a what's the word I'm looking for? You don't need a prescription for that. You don't need an order for that. That's something within your nursing scope that you can use, that you can exercise. All right. If you're assessing, if you see, okay, late decels, that's why we have to learn all this stuff, both LPNs and RNs, because what we have to use our nursing knowledge, okay, to be able to intervene, and help assist that provider with care for that patient to keep them as safe as possible. All right. So the provider's doing all the diagnosing. They're going to be the one to write the orders, but it is up to the nurse to carry out those orders if it's within our scope of practice, and B, we're going to be the ones that's going to make that patient feel comfortable, feel safe, feel like we know what we're doing. Okay. So you have to know this stuff, and especially in this specific order, because the order of things is going to be what trips you up, especially on priority questions. So always know what you're doing and why. Okay. So late decels, first thing you want to do is put them on the left side. Okay. The thing that's, the dangerous thing about, or the priority dangerous thing about late decels, once again, is because that lack of oxygen, lack of nutrients, the insufficiency. All right, especially with that blood flow. So the first thing that we can do is help restore blood flow. Okay, lying on that left side is the easiest way to do it. Next thing you want to do is give them oxygen. Give the mom oxygen. Okay. If the reason behind that late deceleration is more than likely placental insufficiency, it's only a matter of time before the how do I want to say this? It's only a matter of time before that starts to take effect. Like, your body starts to compensate when, for example, if, like, with the placental insufficiency, your body's going to start to compensate for that placental insufficiency. So it's going to try to make up for what's falling, what's being deficit, like what's lacking. It's going to try to make up for it in other ways and in different areas of your body. So usually that happens, especially when it's like a blood volume or like a a fluid volume insufficiency, usually the compensation will be to pump whatever it is, like pump blood faster. That's usually that's usually the not compromise. What's the word I'm looking for? Jesus Christ. But yeah, it's usually how the body tries to make up for not having enough fluid, blood, whatever, it pushes whatever it has even faster. So that's usually why when people are bleeding out or hemorrhaging, their heart rate goes up, because it's like, shit, we're losing volume, so let's try to increase the rate so that a little bit of blood that we have can reach the important places faster, especially because we don't have enough. So yes, you want to left side, you want to administer oxygen, compensate, thank you. Ooh. You want to give them oxygen, and then IV fluids. Okay, if you have a deficit in fluid volume, blood volume, whatever it is volume, IV fluids are usually part of the treatment or intervention, because you're replacing whatever is being lost, the volume that's being lost. Next thing you want to do, if they are attached to oxytocin, you want to turn it off. Okay, late decelerations are bad. All right, you want to turn off the oxytocin, because remember, oxytocin speeds up labor. Okay, and if you have placental insufficiency and late decels, that doesn't mean, okay, let's hurry up and turn up the oxytocin so we can just hurry up, get it over with. Absolutely not. Okay, you want to turn off the oxytocin, you want to slow down or pause that is as fast as possible or as much as possible until you deal with the placental insufficiency. Okay, and then the next thing to do would be to call the physician. And honestly, that part, the call the physician, depending on, I've seen this two different ways, depending on either PN or RN. The actual interventions stay the same, but who you call depends on your scope of practice, because you're supposed to go up the chain. So if you're an LPN, or you're about to be an LPN, about to take your PN NCLEX, and it has left side oxygen, IV fluids, turn off oxytocin if they're attached to it. Instead of saying call physician, it may say call the attending call the charge RN, call charge nurse. Usually it's call the RN. That's if the physician's not there as an option, go up the chain, it'll be RN. For RNs getting this question, it won't say call the PN, it won't say call another RN. Going up, you're calling whoever the provider is. Okay, so that's one of the main differences, if not the only differences, between NCLEX RN and NCLEX PN. Okay. So somebody said lion. Kiss my dimples, lion. Oh, left side, IV fluids, oxygen. What was the N? What was the N in lion? Kiss my dimples. Tell me, because that's cute. I like it. Tell me what N is. I like that. Left side, IV, oxygen. Well, oxygen goes before IV. So it's loin. Guard your loins. We'll come up with it. It's real cute though. All right, so veal chop. Like I said, I'm gonna come up with a cute little graphic for it so y'all can keep it. But this, I can't tell y'all how many, I wrote this on my scrap paper during NCLEX and during my maternity exams and during my maternity ATI. Okay, listen. Oh, thank you, Gapster. Let me write this down, because that's cute. Notify The healthcare provider. Great. Wait, let me put that right here. Okay. So we got veal chop, right? And then after we do our veal chops, we're going to do our loins. Okay? Like a pork loin, but a veal loin. So you got a veal chop and veal loins. I love it. Loin. I almost forgot what it was. Left side. Oxygen. O2, IV, and then notify. I'm gonna just put notify. I'm not gonna put notify. Notify somebody, y'all. I love that. Lion. That's so, I meant loin. Love it. All right. So, damn. Ooh, I went super over. That's fine. All right, guys. So this was the end of part 2. All right, part 3, we're going to continue tomorrow. Okay. With part 3, we're going to talk about, well, first let me summarize everything we talked about today. All right. We talked about the 4 types of pelvises. We talked about the 4 stages of labor. We talked about the types of breech presentations. We talked about the lochia. Okay, not Nokia, but lochia. And we talked about fetal heart rate, monitoring and interpretation. We talked about, and interventions. We talked about pregnancy complications or conditions that could risk pregnancy for both mom and baby. We talked about the difference between placenta previa and abrupto placentae, all that good stuff. Ooh, yes, we covered a lot today. I love it. I'm so glad. I love it. So now for tomorrow, we are going to cover postpartum assessments. Tomorrow's the 20th, yeah, right? We're going to cover postpartum assessments and newborn assessments. Because right at this point, we have 2 patients now. We have mother and baby instead of just mother and baby within mother. Now we have 2 separate patients. So we're going to go over postpartum assessments in mom. And then we're going to go over newborn assessments in our newborn. So our APGAR scoring. We're going to, I'm going to teach you guys some other mnemonics to help you as far as those assessments. I think we can. I think tomorrow, depending on the timing, we can go over the common maternity drugs as well. I believe so. I think we can do that tomorrow. APGAR scoring, postpartum assessments, and common maternity drugs. Okay, this is going to be tomorrow at 7 p.m. Same time, same place. Thank you guys so much for joining me. Now, if you want to watch yesterday's replay, even this replay, you got to be a wonderful subscriber of mine. Okay. Now, if you do want to watch these replays, all you have to do is hit the subscribe button in my profile. You can subscribe for only $2.99 a month. That's it. You'll get exclusive access to these replays. Especially useful for anybody else that maybe couldn't join the live, or if you just want to review the replay from the live that you just went to, you can do that. Just gotta pay your $2.99 a month, and you'll have instant access. Like I said, just tap subscribe in my profile. There you go. Remember, our study gummies are now live. Okay, our study gummies are now live. These will sell out, so please do not get got. Run, do not walk, because when these sell out, don't say I didn't tell you. Do not say I did not warn you. The pins for LPN, LVN, and RN. I think I tried to do this yesterday. It didn't work. Nope. Okay, so LPN, LVN, and RN. Yeah. All those are officially available as well on a website. So you can definitely check those out. Remember, if you have not signed up for the last week of our Back to Nursing School kind of pep rally campaign, whatever you want to call it, this is the last week, and this last week we are focusing on maternity, which is why we're having this wonderful review. If you want to watch the other replays of the previous weeks where we talked about nursing skills and clinicals, Med-Surg 1, cardiac and endocrine, if you want to look at those as well as the NCLEX Jeopardy from those, you gotta be a subscriber. All right, so once you hit subscribe and actually become a subscriber, you'll be able to have instant access to those things. As another perk and a thank you for subscribing, once you subscribe, you'll be